I'm going to bring up our next speaker, Dr. William Clearfield, who's been a very well-noted speaker with us here at NOMA and really considered one of our closest friends here. Dr. Clearfield graduated from the College of Osteopathic Medicine and Surgery, now known as Des Moines University. He interned at Metropolitan Hospital in downtown Philadelphia and followed that up with a residency in obstetrics and gynecology and family medicine. He's with over 30 years of medical experience. I think he wants to edit this bio, Jim, but
Still using this lame.
Okay, I'll let you introduce yourself. No kidding. But actually, as you guys all know, Dr. Clearfield brings cutting-edge material to us all the time, and I think this is the best way to introduce him. And he's kind of our cutting-edge guy. He brings like this really brilliant stuff for all of us to be aware of and make the lives of ourselves and our patients a lot better. And he's going to talk to us today about the endocrinology of psychiatric illness post-TBI. So big round of applause for Dr. Clearfield.
Right. Well, thank you for that. So I'm sorry I missed the singing last night. So, all right, Dr. Bauman and I, we went to the same high school together, and we'll sing our high school song for you a little bit later. So, okay, so most of you guys who've seen me before, we spend most of our time in hormone optimization, and as time goes on, we expand our horizons a little bit more and a little bit more, because we get a lot of patients who have been to the big medical centers, the specialists, the big medical centers, that medical center, and they come to us and they say, is there anything else? And so our focus is always through what I call a hormone-centric lens, and so it goes with psychiatric illnesses. Now, very severe, obviously, hospital-based, those kinds of patients. We're not going to, first of all, we're not going to see them, but if you have patients that have all sorts of psychological, psychiatric issues, and you're not getting anywhere with them, and they're on two drugs, 3 drugs, 4 drugs, they've been to the psychiatrist, the psychologist, the iridologist, they've been to the ashram in India, and they're on 4 drugs for depression, 3 drugs for anxiety, and then 6 drugs for to counteract the other 6 drugs. You really need to take a look at their hormones. I have nothing to disclose, and our objectives are, we're going to use a traumatic brain injury as sort of a model. But we're not going to delve into that. We've talked about that in this group before. But we're going to use it as a model for behavioral issues and mood disorders and those issues. Our basic look is going to be in neuroinflammation. We're going to talk about 10 hormones, 7 major ones, 3 minor ones, and mental health. And then we're going to flip it around, and we're going to talk about mental health maladies and what hormones might be affected. And then we're going to we'll do some remedies. I only have about an hour here, so we're going to go quickly. There's a lot of slides here, but a lot of them are just summary things, and if you want them, you can take them home and have them as a reference. And so patients with traumatic brain injury, and it could be an injury so traumatic brain injury is a physical injury. PTSD is considered a psychiatric illness, which is an outgrowth for a sequela from traumatic brain injury. But we see all of these types of issues that happen immediately and then down the line. Blood-brain barrier damage, mitochondrial dysfunction, impairment of glucose metabolism, increased glutamate. So glutamate is your activating, your agitation neurotransmitter. Cerebral edema, cerebral hypoxia. And you see these things in a traumatic brain injury. And when you look at chronic behavioral issues, you're going to see the same types of, here you go. Here you go, Dr. Bauman. Got it? Okay. All right, you're going to see the same types of issues. There's a strong association between different types of brain injuries, mood and anxiety disorders. Traumatic brain injuries and neurobehavioral alterations are the #1 contributing factor to long-term disability, inability to maintain relationships, and parenting issues. And chronic traumatic brain injury sequela is a template for psychiatric illnesses and neurodegenerative brain diseases. So we're going to see all sorts of disruptions. with any type of brain injury. And brain injury could be a physical injury, it could be a oxygenation injury, so these are your strokes, atherosclerotic issues, it could be neurodegeneration. We're going to sort of use that as a sort of catch-all term. And we'll see, again, disruption in the blood-brain barrier, cell damage, cell death, neuroinflammation, and free radical cytokine release. And we're going to take a look at that. And we're going to take a look at cytokine release in different types of mental illnesses. These are the cytokines that we're interested in here, because this is what happens with neuroinflammation in trauma, infections, immune insults, vascular insults. You get an outpouring of these cytokines, interleukins 1, RA, 4, 10, 11, and 13. And then also over here, TNF alpha and interleukin 6. And those are the main cytokines that we're going to find having an issue. And these are social issues, social problems. So social interactions, emotional issues, sleep, exercise, food, sort of generalized lifestyle choices. Genetics can play a part in it, socioeconomic disparities, industrial pollutants, cellular issues, the disruptions in the microbiome, and allosteric overload, and predictive codings, and whole brain remodeling. And then what we'll see is that you're going to end up with physical issues like strokes, epilepsy, those kinds of things, and then anxiety, depression, schizophrenia, autism are the mental disorders. These are the four main areas of neuropsychiatric or emotional issues. So cognitive issues, emotional issues, behavioral issues, sensory motor function, and then specific areas of impairment. And what we're going to find is that at the end of the road, we're going to be able to map out hormonal abnormalities that will fit nicely into each one of these categories. So, diagnosis of, talking specifically of, oh, that's better, right? Psychiatric, psychological issues. So there's some screening tools that we can use, and these are fairly simple to find. You can find them online. I have a couple of them actually in the slides here. So the Patient Health Questionnaire 2, Patient Health Questionnaire 9, it'll take you less than 3 minutes really to either ask the questions, or you have it part of your patient intake, and then generalized anxiety disorders. So this one is generalized anxiety disorder number 7. So within the past 3, 6, 9 month intervals, you're feeling nervous? Are you able to control impulses and worrying? Do you worry about too many different things? Trouble relaxing, being restless, that it's hard to sit still, feeling annoyed or irritable, and feeling afraid that something awful might happen on a scale of 0 to 3. Add up the scores, and it's fairly simple to do. It's an easy way to do it. This is the Patient Health Care Question 9. The first two is actually the Patient Health Care Question 2. So little or interest or pleasure in doing things in the 2 weeks prior to taking this little exam, and feeling down, depressed, and hopeless. And again, 0 to 3. And then you can add in these other questions. And again, these are easy to find. You can find these online, and if you get lost, and a lot of the EHRs, I know the one I do, has it already built in. You just pull it right up, and you can ask these questions. This is one that we've put together. This is was started out with our head injury patients, but we pretty much use it for everybody now. It's 24 questions. There's 10 in the mental psychological area, 14 in the physical area. We ask them to do an overall score. We do this before first time we see the patient. We give them 5 copies of this, and we have them send us back once a month, and we try to get them to compare it to when we started, not how they have been in the last month, on a scale of 0 to 10. And we ask them about things like sleep, emotions, memory, libido, sexual interest or pleasure, senses of well-being and calmness, and then some physical characteristics also. If anybody wants, let me know if you want this one. This is one we made up, and we like that a lot. So So we're looking at comorbidities, neuroinflammation, and excitotoxicity and oxidative stress. And so traumatic brain injury, that's your physical injury. Post-traumatic stress disorder, that's your psychological issue. They sort of commingle and overlap each other. And we're going to come back to this term again and again, executive function. If you don't know what it means, we'll spell it out in detail. And we end up with memories and fear retentions and fear extinctions. So that's our sort of our pathophysiology. This is another look at the cytokine issues that develop with neuroinflammation, and we get to get improvements. So it is a little bit backwards. So improvements, we want an increase in particularly interleukins 4 and 10. Those are the anti-inflammatory cytokines. And we want to dampen down interleukins 1, TNF-alpha, interferon gamma, and interleukin 18. So, what am I talking about? So these are major psychiatric and psychological disturbances, schizophrenia, depression, bipolar disorder, anxiety disorder. And what I have mapped out here for you, and obviously, unless you have a photographic memory, you're not going to remember all of this. These are the cytokines. These are that have been found to have been produced in each one of these disorders. And you see there's a lot of overlap in all of them. And interleukin 6 and TNF-alpha seem to be the common denominator between each one of them. Traumatic brain injury, interleukin 6, TNF-alpha, and you go through in each one, and it seems to be a common denominator. So that would seem to be a place to start, a way to go. So psychiatric sequela, if we do not check the neuroinflammation, patients can start out with migraine headaches and fatigue, and it goes all the way up to bipolar depression, Alzheimer's disease, multiple sclerosis, and then physical suicide or suicide ideation. Long-term sequela of traumatic brain injury, just as a reminder, on Axis 1, 26% of these patients, this is 3 months post-traumatic brain injury, 26% of these patients develop this, and again, this is new onset major depression, new onset substance abuse, phobias and paranoias. Those are Axis 1. Psychiatric disorders. Axis 2, 34% of these patients develop new onset borderline personality disorders, obsessive compulsive disorders, paranoia and avoidance, and antisocial behaviors. So, and again, these are new onset. These aren't either extensions or exacerbations of old ones. Psychological sequela of traumatic brain injury, 50 to 77% of these patients within 1 year experience major depression versus 20% of the regular population. 44% of the patients suffer from comorbidities, and 10 to 30% experience what is known as treatment-resistant depression. And the treatment-resistant depression is patients that are on 2 or more anti-psychological or psychiatric medications without relief. So how effective are antidepressants? 20 to 40% of the patients with placebo notice improvement within 6 to 8 weeks. With antidepressants, that should be 40 to 60% of the patients improve within 6 to 8 weeks. And a conclusion is 60% respond within 2 months. There's a 50% reduction in symptoms, and about 80% of these patients stop their medications within 1 month. But we're looking at more of the long-term patients. And again, so we're looking at hormonal issues that deal with these different psychologic and psychiatric issues. And just for fun, because I said, well, what does testosterone have to do with depression? What does growth hormone have to do with depression? You can do a Google search, and they changed it so it doesn't tell you how many hits you get anymore, at least what I have. But so I couldn't do a new one, but up to January of 2022. So this was just in the 2 years between January 20 and 22. There were 16,000 articles on testosterone and depression. That was in a Google Scholar. And as you can see here, cortisol and depression, quite a bit. Thyroid and depression, quite a bit. So the point being that for your your psychological patients, those that are having difficulties with behavioral issues, mood disorders, those kinds of things, and you're not getting anywhere with them, you really need to take a look at their hormones. So we're going to look a little bit more closely at where the problems might be, and so we can be a little bit more specific in what we want to accomplish. So again, any type of head injury. Remember where the hormones are generated. They're generated in the hypothalamus and the pituitary. That's where all the action begins. And remember, the hypothalamus has no blood supply, so any disruption in the cerebral milieu, you shake the head up, it's only has two thin nerves that innervate the hypothalamus. The pituitary has two very fine arteries, so they're easy to tear and they're easy to disrupt. And you're not going to see issues of change right away, usually. Most of the time you're going to see, unless they're unconscious, but usually it's 3 months later, 6 months later, a year later. We've seen it up to 17 years later. We can trace it back to some sort of a head trauma. And those of you that deal with psychological and psychiatric issues a lot, and even just general practice, we see it all the time. You can actually trace these things back to some sort of trauma a lot of the time. So the hypothalamus, just real quick, we should all know this. It's located at the base of the brain. It maintains the body's internal balance. It's the link between the endocrine and the nervous systems, and it produces key functions such as heart rate and blood pressure maintenance, body temperature, fluid and electrolyte balance, appetite and body weight, glandular secretions, and it produces the pre-hormones, the releasing hormones that stimulate the pituitary gland to release their hormones. So this is a schematic of the hypothalamus, and these are the releasing hormones. This is the anterior pituitary, their hormones, so the sex hormones here, cortisol here, thyroid, prolactin, and growth hormone. The posterior pituitary releases ADH and oxytocin. And these are the organs that it affects. So just a schematic there, just as a reminder. Not sure what that is. Stages of early effects of hormones in early injury. So the process activates microglial activation, reactive oxidative stress, and epigenetic mechanisms will contribute to the sort of ongoing neuroinflammation and damage, and that'll happen within 72 hours. Hormone levels drop in the stage 1, which is in the first 2 to 4 hours. Testosterone up to 80%, IGF-1 up to 20%, cortisol 50%, and then later on, 3 days later, only 3 days later, the thyroid takes over. TSH will drop, and testosterone will drop sometimes by up to 95%. Hormone levels that rise are prolactin, which is under the influence of a negative influencing factor. So a disruption in prolactin influencing factor causes a rise in prolactin of up to 60%. And this is a schematic of the hormones and their changes within 4 days of a so the black is 96 hours. The white is 24-hour changes in, this is cortisol, this is free T3, thyroid, this is prolactin, and this is the male, this is testosterone. And as you can see, it's almost 75-80% drop in testosterone within 24 hours of some sort of brain disruption, and almost 100% within 96 hours. Now, a lot of them do recover. And this is just a reminder of which hormones are produced in the hypothalamus. This is sort of basic. I'm not going to read through this for you. This was just sort of for reference. So clues that there's a hypothalamic involvement in your in your patients, in your psychiatric patients. You get elevations in growth hormone without any type of physical change, so there's no pituitary adenoma. Elevations in prolactin, low peripheral testosterone, elevated insulin, suggestive of a metabolic syndrome. And if you'll remember, testosterone issues and insulin issues that are wrapped together in young females, that's polycystic ovaries. TSHI index of less than 1.3, and we'll talk about what that is in a few minutes. Syndrome of inappropriate ADH, and in the military, especially from the Middle East, they had blast wave injuries. Pituitary is bean-shaped. It's 8 by 10 millimeters, and it's located directly behind your nose and between your ears. So, again, go from the bottom of the chin to the top of the head, and from ear to ear, where that meets, that's where your pituitary should be. These are, again, the hormones of the pituitary. The posterior pituitary, oxytocin and ADH are generated there. And so what are some of the properties? What are we looking for? So in testosterone, testosterone improves cognitive function. It's a mood stabilizer. It's useful for motivation, strength, energy. And in deficiencies, we see anxiety, depression, loss of self-worth, loss of muscle tone also, urinary incontinence, and with females, vaginal dryness, poor libido, and males, erectile dysfunction. Testosterone is inversely related to blood sugar levels, so levels of insulin resistance. Testosterone attenuates inflammatory cytokines, particularly interleukin-10. Remember, interleukin-10 is an anti-inflammatory cytokine, so it will increase interleukin-10, and it will be effective against interferon gamma, interleukins 3, TNF-alpha, and also that interleukin-6. Remember when I showed you that slide earlier that almost all of those psychiatric and mood disorders had some form of interleukin-6 and TNF-alpha involvement. It protects against mitochondrial dysfunction. It improves seizure control. Testosterone is also extremely valuable for chronic joint pain, low back pain, neck pain. Those of you who deal with patients, especially men, who have adequate testosterone levels going from inadequate, and they've had lumbar issues, low back issues, thyroid issues. A lot of times they'll tell you that their symptoms are much improved. Testosterone decreases pain, anxiety, improves cognitive function. It modulates anorexia nervosa. So your patients who come in with eating disorders, again, take a look at testosterone. Testosterone levels are inversely proportional to degrees of depression, and we can actually measure and get. We have measurements here. This was done by Barton here, and here's the reference for it if you need it. And can actually get measurements. Now, remember what your normal testosterone levels are. For one lab, it's 250 to 1100. Another lab, it's 264 to 916. Those are the two major labs, at least in Reno. The hospital ones have different scales, but those are the scales. Where do those numbers come from? You know where those numbers come from? Those reference ranges, you know where they come from? It's 2 standard deviations, right, of whatever you're measuring. So let's take vitamin D. 30 to 100 is normal, right? It's 2 standard deviations. 95.4% of a sample, that's what's looked at as normal. Now, if we go to up to college here, or Bruce is going to give us a quiz afterwards and say we don't get our credits unless we pass. A passing grade is 95.4% of the class will pass. Well, that works fine for this, but okay. So back to vitamin D. So 30 to 100 is normal. So 32 won't be flagged. It's normal. 96 is normal. 29 is not normal. 31 is normal. 98 is normal. You see a problem there? Huh? Well, the 2 major labs in Reno. That's the. Yeah. Mm-hmm. Okay. So the I'm just trying to point out that where these ranges come from. Okay, okay. So normal for one lab is 264, and another lab is 250. But look at this: at risk 295, and free 6.0, and frank depression at 148, and at risk free 3.0, and for females at risk 22, and free 1.0. And you're going to see levels here like 9 to 55 is normal for females for testosterone. And at frank depression at 11 and 0.5. So, if you write a prescription for testosterone and you get a nice, cute letter back from their insurance company saying, well, first of all, you didn't do 2 of them in the morning, and they were 298, or they were 301, so they're normal, and we're not paying for it. Okay, so again, we're looking at patients that are, you've been through the ringer, you've given them their SSRIs, they've been to the psychiatrist, they've been to the psychologist, we're still not getting anywhere. Okay, traumatic brain injury, low testosterone leads to depression, and we saw the numbers there. And this is where you're going to see suicides and suicidal ideations. Men have 4 times the risk of suicide as females. I got this from Dr. Davidson, actually at this conference a couple of years ago. Peak years for suicide, this is just an aside, for men ages 80 to 90, that was according to him, and for women 50 to 60, and he attributed it to the loss of estrogen. That was from Dr. Davidson a number of years ago. Estrogen drives blood flow to the brain. So when we first started doing hormone replacement for guys, we would get their testosterone levels up to about 1,500 total, and then we would give them estrogen blockers so that the estrogens went to 0 because we didn't want gynecomastia, which is one of the issues with it. They ended up calling me and telling me that they're falling down. They put their car keys in the freezer. One guy ended up at Black Rock out in the desert. Didn't remember how he got there, and it became apparent fairly quickly that estrogen drives blood flow to the brain. If you get the estrogen levels down to really less than 10, you're going to start seeing these memory issues. So it modulates pain. It increases under stressful conditions, and it modulates critical illnesses and trauma. Estrogen will increase neurotransmitter function, manual dexterity and speed, and long-term memory. There's a whole movement in the anti-aging world now. There's a whole group who have decided now that estrogen is a good thing for men. And in fact, one of the speakers at our last conference told me that he's 70 years old. He takes 7 milligrams of estradiol a day. Craziness, and his goals for his patients are total testosterones of 2,000 and an estradiol of 150. I'm just reporting it. I don't agree with that at all. When we first started out, we really didn't have anything to go on, and just kind of the gym rats. That's who that was using all this stuff. That's probably why testosterone's a controlled substance, because I can't really figure out any other reason for it. And they were just overdosing themselves. But if you use physiologic doses, you're not going to run into those problems. Estrogen prevents neuronal loss in the CNS. It's the strongest predictor outcome of acute mortality and a poor long-term outcome. And estrogen levels are decreased in the prefrontal lobes in Alzheimer's disease, and it aids in the recoveries of strokes and traumatic brain injury. So estrogen is a good thing to have. For guys, we wanted an ideal level is probably about 15 to 25. Usually when we get over 40, we're going to start seeing some behavioral issues, emotional labilities, those kinds of things. But you don't want it down at 0. You see an estradiol of 0, that's a warning. Guys need some estrogen, and gals need some testosterone, so just keep that in mind. Progesterone, in the second half of the cycle, progesterone is sedating. It has analgesic effects. It improves visual memory. It improves proliferation and differentiation of osteoblasts. It actually improves bone strength, and it is immunosuppressive. Progesterone is one of a group of hormones known as neurosteroids. So this group, Valou, was the main researcher in France in the mid-'80s, and they found that a number of hormones, and the main one, progesterone, is produced independently in the brain versus the periphery, and so they act as fine-tuning mechanisms or microhormones. So any disruption in the brain, you're going to get a disruption in those symptoms. And again, progesterone is one of your main sedating hormones. It's extremely calming, and it becomes depleted with actually with testosterone. Excess testosterone will deplete progesterone, and that's actually that imbalance is where you get your so-called road rage from. So progesterone stimulates the body to make allopregnenolone, which is your hormone that stimulates GABA production, so the calming neurotransmitter. Your benzodiazepines, Valium, Xanaxes, whatever, stimulate the brain to make allopregnenolone. It does the same thing. So we can actually avoid the side effects from the benzos by making sure the patients have an adequate amount of progesterone. Males also. This was a class we did a couple of years ago on the progesterone. This was pros and cons after hysterectomy. You know, the popular belief is if you don't have a uterus, females, you don't need progesterone, and you know that's wrong on so many levels. And it's wrong on all of these levels. The only reason that it's right is that it induces a period and lays the foundation for pregnancy, which after hysterectomy, you know, is no longer necessary. But it is sedative. It's analgesic. It improves bone strength. It improves the immune system. It regulates glutamate GABA balance. It improves thyroid function, and it reduces all of these things. It actually mitigates cancer risk. Memory loss, slowed thought process, stress, anxiety, depression, insomnia, thromboembolic risk. So this was actually the conclusion from that class there, and if you want the references for all of that, you know, we have them. So progesterone will stimulate in that steroidogenic pathway the production of allopregnenolone. Why do I bring that up? Low progesterone will have all of these symptoms that we've talked about before: memory loss, slow thought, decreased comprehension, anxiety, depression, suicide ideation. It will have a decrease, and when you get decreased GABA, which is progesterone produces, when you get decreased GABA, you get all of the same symptoms. And the antidote, you know, so in our modern pharmaceutical society is, again, the benzodiazepines. The benzodiazepines stimulate the brain receptors to make allopregnenolone, which generates GABA. They work exactly the same way. There's the references for that. Alzheimer's disease, I actually already mentioned this. Progesterone is neuroprotective in the pathogenesis of Alzheimer's disease. It has positive effects on glucose metabolism, and actually increases the expression of the Krebs and PPAR gamma receptors. PPAR gamma receptors are what? There's drugs that are PPAR gamma receptors, right? Actos, right? Avandia, is that one off the market? And then we come to executive function. So this deals with memory, concentration, the ability to start projects, the ability to finish projects, the ability to multitask easily, the ability to accomplish tasks easily, and the ability to complete tasks. Also, obsessive-compulsive tendencies, dark moods, paranoias. Pretty much what I just said. And this was when we're seeing our TBI patients and their behavioral issues. This was kind of our aha moment, because growth hormone deficiency is a lack of or a diminishment of executive function. So these are symptoms here of traumatic brain injury, and we looked at autism. And as you can see, they match up pretty well. And in autism, what you're going to find is you're going to have these young babies when the parents notice that there's something wrong with them. If you get a measurement on them, you're going to find very high growth hormone levels versus their peers, and then very low IGF-1 levels. And if you remember the cascade, growth hormone needs to be conjugated to IGF-1 in the liver for it to be useful. So we have these babies with really big heads. You know, all babies have big heads, but really big heads, but they're empty. It doesn't work. And that seems to be one of the niduses of autism. So there's a couple of big medical centers in New York City that are actually treating the autistic kids with IGF-1, which they have high growth hormone levels. You would think if they gave them IGF-1, it would make it worse, but it actually it improves their behaviors. And so that's a clue right there. So what can we do with that? So we can expand that out into the rest of our psychiatric and psychological issues or patients. So again, growth hormone is attention, executive function, cognitive function, being able to finish projects, start projects, multitask, and then there's mood issues, anxiety disorders, and physical health. And then when we improve the growth hormone levels in any which way, we get an improvement in especially these types of symptoms: outbursts, hostility, anxiety, somatization. This, just for your reference, we measure routinely growth hormone IGF-1 as a screen. Growth hormone levels and IGF-BP3, they get to be a little expensive. If we have an issue here and we have patients who have those types of symptoms we just mentioned, we'll get the full panel. This is sort of a brief treatment algorithm right here. I'm not going to get into that right now. But we use peptide. We did use peptides till the FDA pulled them pretty much off the market in the past 2 months for no reason really. 2 to 4 sprays. We have some secretagogues, which are homeopathic remedies, and we use 2 to 4 sprays, and we get about a 25% increase in IGF-1 within 6 months using these secretagogues. We got about a 50% increase using the peptides, and I don't know what's going to happen with them. Real growth hormone is very expensive. There's some legal issues with it, and it's a little bit tricky to work with. So we've done very well. I mean, I'd say 90% of our patients that have some growth hormone issues, we can get away with, get adequate results from the secretagogues and peptides. Some of the secretagogues they're over the counter. They're not prescription, and they're 1/20th the price of real growth hormone. So thyroid function and depression, you're going to see a low T3 but a mid-level T4, and you're going to see an increase in what is known as reverse T3. So reverse T3 is a T3 that is produced under usually stressful conditions, high cortisol, but also with sometimes diabetes, or some extreme, emotional stress. So we get a reverse T3 on every patient. Again, the normal is 8 to 25. We start seeing symptoms at when the patient is at over 15, though. We can do a free T3 to reverse T3 ratio, and we manipulate it just so we get easy numbers. We take the free T3, multiply it by 10, divide it by the reverse T3, and that anything over 2.0 is usually adequate. So what we're looking at is a comparison of the thyroid function to cortisol or stress hormone. We want that to be over 2.0. If it's under 2.0, we have some sort of cortisol abnormality. So symptoms that you would see with this type of patient would be patients who awake in the morning and they're tired. That cortisol awakening response is not functioning. They need something to keep. Then they get a little bit of a burst of energy, but between 10 and 11 o'clock, they become fatigued again, and they need something to keep them going: coffee or tea or Red Bull. In the afternoon, they feel like they need a nap. By dinner time, they're exhausted. Later at night, 8, 9, 10 o'clock, they get a second wind, and then they're wide awake. That's when they do their best thinking, and they do their best work. Does that sound like you, that sound like you? I see you nodding. And patients usually have sugar and salt cravings that go along with this. And if you ask these questions, you're going to find out that this is pretty common. So total T3 levels are inversely related to cognitive performance. Those with high total T3 levels show little impairment in memory, and those with T3 levels at or below the normal boundary range do poorly compared to their healthy controls. In psychiatric issues, the thyroid component influences dopamine, serotonin, glutamine, and GABA. And thyroid, you can consider that as a fine-tuning mechanism also. Cortisol, stress hormone, as you know, affects the whole body, and it can affect the circadian rhythm, mood, water and sodium balance. It influences the DHEA to insulin ratio, bone remodeling, libido, weight control, GI issues, especially fat metabolism, and decreases in amino acid uptake. The effects of stress, I found this picture here. Barack Obama, 2008, 2016. I think it just, I don't think this needs any explanation. Cushing's disease and Addison's disease. So Cushing's disease is excess cortisol. Addison's disease is not enough cortisol. I think those are pretty self-explanatory. But what we deal with a lot is in between. What happens in between? What happens if they have the low normal cortisol, right? But they have, where is it? A lot of these symptoms. So we'll see this. We'll see mood, hair loss, weak, frail, IBS. Patients are coming in and they'll tell you these things, but their cortisol levels are normal, mid-range or low normal. So typically we say, well, there's nothing wrong with you. Go home. You need to go see the psychiatrist who's always been with them, or on the other end, Cushing's disease. So there is a term that if you look it up, you can put it in your search engine and write in the first 10 articles that'll come up is there's no such thing. And the term it's been termed adrenal fatigue. So it's not Cushing's disease, it's not Addison's disease, it's in between. It's symptoms of both, either one or the other, but it's not clearly there. So, it's like, you're not fat enough. We want to give you GLP-1, but you're not fat enough. So go home and gain 20 more pounds, and then I can give it to you. I mean, it just makes no sense, right? So adrenal fatigue, as I just explained, I just described it to you. You wake up in the morning, you're tired. You get the second wind later at night. The nights and days are sort of mixed up. Circadian rhythm is all out of whack. Again, psychiatric, psychological issues develop with this. Poor circulation, depression, poor libido, weight gain, insomnia. You can look at the ratio between cortisol and DHEA. So you all know that cortisol and DHEA are antagonistic to each other. So if you have high cortisol levels, DHEA will temper that. And if you have low cortisol levels, DHEA will temper that. So it will normalize things. DHEA is your antidote for cortisol. DHEA is an antidepressant. It was actually approved in 1952 by the FDA as an antidepressant for a major depression and bipolar depression. We don't use it for that anymore, but it's the same stuff. It's basically a mini testosterone. It's the precursor. It's one of the ingredients of testosterone. It relieves, it improves bone density. It lowers LDL lipids. It protects against cortisol catabolism. It improves insulin sensitivity. It improves myelin sheath coatings, and it helps relieve fatigue, dry eyes, and dry skin. If you don't want to use testosterone for whatever reason, DHEA is over the counter. You don't have to write a prescription for it. The doses are usually about 10 to 25 milligrams for females, 50 to 100 milligrams for males. This is just a mark for the DHEA cortisol ratio, which I just told you about. and the ratio should be about 5 to 1 if you do cortisol to DHEA in the blood, and it should be 0.5 to 0.05 to 0.32 if you do a saliva test. Pregnenolone is the hormone of memory. That's the second hormone in the steroidogenic cascade. It comes from cholesterol. Remember that stuff we told everybody not to eat for in the 80s and 90s, and then everybody got fat from after that. So pregnenolone is the hormone of memory. It's a precursor of progesterone, and also the precursor of DHEA and androstenedione, sorry. So pregnenolone, again, is the hormone of memory. We measure this on every patient, we'll replace it. So lab blood levels, about 90 to 110 is our sweet spot, and you'll find patients that it'll register 0, it'll register 30. Replacing this takes a long time, but we do it. We tell this patient, this is a long-term sort of remedy. It takes a year before you're going to, 6 months to a year before you're going to notice anything. But if you have them stick with it, you'll find, and we do very well with this. 50 to 100 milligrams. Pregnenolone has anti-aging effects, is anti-arthritic, it has anti-stress, it's a mood elevator, it improves mental awareness, it enhances memory and cognition, it's anti-fatigue, and it has actually been used as an antidepressant, particularly postpartum depression in very high doses. I told you that sort of for memory dose is 50 to 100 milligrams. We've used 400 milligrams for pregnenolone. Remember, it's in that cascade that goes from pregnenolone to progesterone to dihydroprogesterone to allopregnenolone, which stimulates your GABA, your calming neurotransmitter. 400 milligrams for about 28 days. It also increases acetylcholine and improves cognitive performance. This is the cascade I just mentioned to you. And just briefly, converting progesterone to dihydroprogesterone, and it's not on the chart here. The allopregnenolone is here, which stimulates GABA, but it's converted by 5-alpha reductase. Remember, your testosterone to dihydrotestosterone is converted by 5-alpha reductase. And so your finasteride and your dutasteride, 5-alpha reductase inhibitors, we wanted to block that testosterone to dihydrotestosterone to, improve your hair and improve your enlarged prostate. But what had been frequently overlooked is that it'll block this pathway also. And what did I tell you shows up down here at the bottom here, which is off the screen, is your allopregnenolone. And there's a small but very substantial subset of patients who use 5-alpha reductase inhibitors who develop severe, and I mean severe mental disabilities, severe depression, severe anxieties. There's been suicide cases that have been traced to 5-alpha reductase inhibitors, and it comes from this pathway here. Again, so these are the symptoms for low allopregnenolone, low GABA, just the same order. Then prolactin. So prolactin is a tip-off to treatment-resistant anxiety and depression with low prolactin levels. So prolactin, again, we measure this on everybody at least once. 11 to 14 is considered normal. Traditionally, we're looking for it, to be very high with pituitary adenomas. But when it's low, prolactin levels at 6, we're just going to see edginess, anxiety, panic attacks, agitation. And it's a symbol of hypothalamic, some sort of hypothalamic disruption. You get decreased production in the anterior pituitary. We saw this initially in our traumatic brain injury patients, but we extrapolated at least once to everybody. And so your patients with severe mental, behavioral issues, take a look at their prolactin levels. It won't be flagged, and again, the labs will tell you 2 to 19 is normal, or 6 to 30 is normal, and it won't be flagged. But under 6. That's kind of a warning, Will Robinson. And these are the patients who come in and, they're on 2 or 3 antidepressants. They've been to, any number of practitioners, and, nothing seems to work for them. So the point is to take a look at these. Again, there's the normal range, 2.5 to 19. And again, what you'll see is when it's low, you're going to end up with a low GABA levels. You're going to have low LH. You're going to have low testosterone. And so that chart that I showed you before, and again, I'm not going to read it, but if you want this, I can certainly send it to you. So sensory motor function, these are some of the symptoms. I'll give you this one here. Headaches, fatigue, neuroendocrine disruptions, major impairments, estrogen, thyroid, DHEA, and testosterone. These are the hormones that are involved in this issue here. Behavioral issues, since that's what we're talking about, agitation, aggression, apathy, insomnia. We look at progesterone, pregnenolone, and then these are some drugs here also. Cognitive functions, estrogen, growth hormone, testosterone. Those are your major hormones for that. Okay, so let's take a look at a couple of more issues that's specific. So let's take a look at depression. Depression, we get a reactive microglial release of exosomes, extracellular vesicles that carry interleukin-1 and caspase-1. These receptors induce inflammatory reactions throughout the brain, and you get microglial inhibitions within the vesicles targeting the microglia. So again, head injuries, 50 to 77% of these patients develop new onset traumatic brain injuries, and depressive symptoms are usually inversely related to testosterone levels. I talked about the testosterone levels before. These are the changes that you're going to see with depression. You're going to see a decrease in DHEA. Remember, DHEA is sort of like a mini testosterone. A decrease in estrogen, growth hormone, progesterone, and thyroid. You're going to see an increase in cortisol, stress hormone. You can see an increase in thyroid and an increase in free thyroid. These are the cytokines that are involved. Anxiety, so it's a feeling of fear, dread, or uneasiness. Symptoms are nervousness, restlessness, increased heart rate, impending sense of doom, sweating, trembling. This is sort of a cascade. We get, an immune system activation, and it goes through stress, neuroinflammation, brain alterations, microglial activation, loss of that allopregnenolone, failed GABA transmission, which results in your panic disorders, agoraphobia, and generalized anxiety disorders, and that's kind of that sort of the cascade for that there. The hormones that are involved, we talked about allopregnenolone, pregnenolone, and progesterone. The cytokines involved, again, there's interleukin-6. We get a loss of interleukin-10, TNF-alpha, and then the increase in cortisol, dopamine, and, again, thyroid. So you're getting the idea that, we can sort of take a look at the hormones. You can take a look at the cytokines and sort of match them up. At the end of this, I have all of these charts in an order for you, so that you don't have to go flipping through it. So, obsessive compulsive tendencies have a component of growth hormone deficiency. So any patients that have obsessive compulsive tendencies, again, look at their growth hormones. Okay. And if they had head injuries, it doesn't have to be a major head injury, it could be a minor head injury. Patterns of cognitive deficits and MRIs suggest dysfunction of the frontal and subcortical circuits. You get mood changes, changes in social behavior, changes in personality, and diminished executive function. Cytokine changes and hormone changes in obsessive compulsive disorders. Again, growth hormone, that's the major one. Progesterone and testosterone. And again, increase in DHEA. Remember, DHEA is a testosterone wannabe. Cortisol, again, you notice the sort of the theme here. Cortisol is increased in all of them. And in cytokines, interleukin-6 and TNF-alpha. Agitation. Is a continuum of line of the behavioral disturbance from inattention all the way to agitation. Hormones, again, so agitation, you're going to look at progesterone and estrogen, and again, increased cortisol, DHEA, and thyroid. So again, in these sort of agitated states, thyroid is usually elevated, testosterone could be elevated, DHEA, which is a precursor of testosterone, and in decreased are your female hormones, estrogen and progesterone. Aggression, you're going to see pretty much the same thing. And surprisingly here, cortisol seems to be decreased, but again, estrogen and progesterone are decreased in aggression, testosterone. And you know, the idea of road rage and testosterone excess, when we're treating patients, if you treat them physiologically, you give them the right amount, don't give them crazy amounts of testosterone, we rarely, if ever, see it. And if it does happen, it's usually sort of temporary, and we sort of back down on even our beginning doses and then bring them back up. I can't think of maybe one or two patients, and I've been doing this for 20 years, that we've had to take them off of testosterone because of road rage. I mean, I don't know if any of you see it, but we just don't see it. Psychosis, there seems to be an estrogen component to psychosis. It has, estrogen has a property similar to atypical antipsychotic drugs, and that severe mental illnesses, specifically schizophrenia, have a significant hormonal and etiological component. Estradiol particularly aids in the formation of dopamine, serotonin, and glutamine, and it is an antidepressant. In schizophrenia, again, estradiol, testosterone, thyroid are going to be low. Prolactin and progesterone are going to be high here, and then there's your cytokines here. In dementia, again, elderly women, they have significantly lower estradiol and testosterone levels, and low progesterone levels in the frontal lobe. In Parkinson's disease, in males, we get decreased androgens across the board. The estrogens remain steady, and patients with low testosterone have sort of the double whammy, especially with Parkinson's disease. Cognition, we talked about pregnenolone. Pregnenolone correlates with cognitive performance. Also, low testosterone will correlate with cognitive issues. And cognitive issues are improved with adequate, again, not too high, not too low. We need to be Goldilocks, testosterone, estradiol, and IGF-1. The hormones that are involved in cognition are, again, pregnenolone, testosterone, thyroid also, and estrogen. Again, the excitatory hormones here, cortisol and thyroxine, and they're low in allopregnenolone, testosterone, progesterone. So I hope you're starting to see a sort of pattern here, theme. What happened? Where do we go? Mood disorders. Again, as I mentioned before, 1952, DHEA was approved for mood disorders and major depression. It modulates the GABA-A receptor, again, the calming neurotransmitter. Mood regulators are estrogen and testosterone and growth hormone. And again, we'll have a whole class on non-hormonal ways to manipulate all these hormones also. I think we're going to do that tomorrow morning, so across the way. So cytokine changes, again, in mood disorders, we got a decrease in estrogen, testosterone, DHEA, and thyroid, and then there's your interleukin-6 and TNF-alpha again. And the reason I keep bringing up the cytokines is you can match the cytokine abnormalities to hormone stimulation or excess or deficiency, and also to your antioxidants and anti-inflammatory agents also. You need optimal levels of estrogen and testosterone for cognitive functioning. In attention disorders, estradiol and progesterone balance is important, as is thyroid, and you'll get again that sort of road rage that again I rarely see it. This is a chart pretty much of all of the hormones here and all of the issues that we've discussed, and which hormones are either in excess or deficiency with each one of these disorders. So this is sort of and here are the cytokines at the bottom here. So this is pretty much sort of sums it all up. And laboratory, I got 1:48. You want questions, or you want me to go through the laboratory real quick? Labs, okay. Okay, so we like these are the labs that we look at. So we look at C-reactive protein. This is for inflammatory. When it's elevated, inflammatory issues. Normal is usually about 0 to 3. We want it less than 1, and I put some remedies in there for you. Also, omega-3 fatty acids, at least 2,000 milligrams a day, and also we use curcumin or turmeric. We use that for pain. It works quite nicely. 500 milligrams once or twice a day, and that works quite nicely for most moderate pain. I mean, there's obviously cancer pain and things like that. It's a whole different story. Blood sugars. So we need to look at blood sugars. Normal fasting blood sugar in most labs now is 65 to 99. Our goal is about 84. And for every point over 84, there's about a 4% chance of developing a glucose abnormality within the next 5 to 10 years. I don't have it on this slide, but if you need that reference, I can get that to you. So a fasting blood sugar of 94 is normal. But that's 10 over 84, 10 times 4, you got about a 40% chance of developing a glucose abnormality within 5 to 10 years. So what does this tell you? This tells you that you have something to hang your hat on and say, hey, your blood sugar is normal, but it's really not optimal. We'll also do fasting insulin, and that'll give us a insulin resistance look. And so fasting blood sugar times fasting insulin, and you can go through the math, but I'll just make it easy for you. Divide it by 405. That'll give us insulin resistance. We want it to be less than 1.9. So you get a fasting blood sugar of 100, but an insulin of 4. Their actually insulin resistance is less than 1.0. Okay, you get a fasting blood sugar of 95, say, normal, but an insulin of, say, 20. If you do the math, 95 times 20 is about 1,800, divided by 4 is about 4.5. That's high. Homocysteine will do this. That's usually a B complex and folic acid deficiency. It's an indicator of damage of the arteries, particularly the coronary arteries and the carotid arteries, increased risk of blood clots, strokes, heart attacks. Our optimal is less than 10. We had a patient came in and had a homocysteine of 31. I sent him to the cardiologist, got a cardiogram. It was equivocal, it didn't show anything. Sent him to the cardiologist. Cardiologist said, what are you sending this person to me for? He's perfectly fine. 4 days later, I get a call from the ER. He's having an MI. He had a 99% LAD lesion. I told him you had a problem. So homocysteine levels, we get this on everybody. Vitamin D, we talked about that. Our optimal is 50 to 80. If you come to the workshop later, we'll discuss what blood levels are and how we got them and what to look for. Estrogen, we measure estrone and estradiol. Estrone goes down the catabolic pathway. This is your bad guy. That'll take you to the 4-hydroxy and 16-hydroxy estrone metabolites. Those are your cancer-causing metabolites. We want the estrone to be under 100. Estradiol, that's your sort of female characteristics, your female type hair, skin, nails, and voice and shape. So estradiol for males, our goal is usually less than 40, and optimal is about 15 to 25. And for females, what we're going to do is we're going to do an estrogen to progesterone ratio. We're going to take the estrone and estradiol, divide it by the progesterone, and we want that to be less than 250. We don't really correct for the units on this one. We sort of worked it out. Less than 250, patients will actually feel pretty good. If it's greater than 250, and as that number goes up, you're going to get more and more symptoms of high estrogen and or low progesterone. When we first started, we didn't get estrone levels, and we did it this way. And a lot of the books lab books will show you a progesterone to estradiol ratio. You need to multiply the progesterone by 1,000 to get the correct units. If it's between 100 and 500, that's sort of our sweet spot. Anything under 100 is estrogen dominant. Anything over 500 is progesterone dominant. Testosterone levels, again, I talked about a normal level. our guys feel good when totals are 700 to 900, and the free is about 2 to 4%. For females, this is the same lab, 2 to 45. I've seen another lab at 9 to 55. If your female patient is at 5, she's not going to be normal. If she's at 45, she's not going to be normal. 30 to 40 is our sweet spot here. These patients are, remember I showed you that when they get down to under 10, females, they're going to be depressed. Sex hormone binding globulin is one of sort of those nebulous things, but remember, testosterone when produced is 98% bound to protein, half of it to albumin, the other half, it's about 44%, the sex hormone binding globulin. We measure this, and we have a formula, and that'll give us the free androgen index. You take the total testosterone divided by, again, this will get it's the right units, 0.288 times the sex hormone binding globulin. Normal for men, 30 to 130. Optimal, about 53 to 55 to 110. For females, 0.4 to 8.4, and about 3 to 6 in the free androgen index. So you can have high total testosterone and high sex hormone binding globulin and low free androgen index. Well, they actually need some intervention. Just a little tip: high sex hormone binding globulin or low free androgen index. Boron, 3 milligrams to 9 milligrams, they come in 3 milligram capsules, will decrease the sex hormone binding globulin by about 50%, and it takes only about 4 to 6 weeks. It works pretty nicely. So DHEA is a precursor, again, of pregnenolone, and and also to the androgens and estrogens. Normal, you're going to find in labs, is 95 to 345. Our optimal is usually about 300 for guys or better, and 200 for females. And I gave you the doses already, 25 to 100. Usually we start at 50 for guys, and for women anywhere from, you can get it as low as 5, and as high, never go more than 25. These are over the counter. Patients can go to the dollar store and get them themselves, and sometimes they'll come in with excess testosterone symptoms, and I found this DHEA, and you can get it anywhere. You can go to CVS up the street here and get it. You don't need anybody, holding your hand. Pregnenolone, again, we talked about. That's your hormone of memory. Normal in the one lab that we quoted, 33 to 248. That's your 2 standard deviations. Our optimal is about 90 to 10, and we'll replace it at 30 to 100 milligrams. This takes time. They're not going to be speaking Portuguese in 2 weeks. You got to let them know that this takes time. I know I'm almost done here. Hematocrit, depending, again, where you live. I live in Reno. It's a little bit higher. When it increases with testosterone, again, we're going to talk about, if you come to this workshop this afternoon, we'll talk about polycythemia and testosterone and why not to worry about it. MCV is a measure of red blood cell size. Over 97, you have B12 and folic acid deficiencies. Under 80 is an iron deficiency. Prolactin, we talked about that. We want it to be over 6.0. IGF-1, and if it's very high, of course, that's a pituitary adenoma, but when it's low. IGF-1, 200 to 250. And then the thyroid we're going to talk about that this afternoon also, but we measure thyroid antibodies on everybody also. And so I'm going to stop there and have any questions. And we're going to be doing sort of a male hormone primer this afternoon, and then I'm going to do a little bit of a potpourri tomorrow, and anything you guys want. If you want weight loss, if you want hair loss, libido, we can do those. If not, I'll do the female, sort of start to finish.
Questions from the audience?
Questions? We check them. So the question is, when do we check them? So if they're postmenopausal, it doesn't really matter. If they're premenopausal, we check them on days 19 through 21 of the cycle. And the reason we do it on days 19 through 21 is that's where you get that second peak of estradiol in the second half of the cycle, and that's where you get the peak of progesterone. So that should be, that ratio, that should be the maximum ratio right there. That way I have a clear idea of where that ratio should be. I should have said that. Thanks.
All right. Any other questions? Going once, going twice. Okay. This concludes the morning session. Thank you very much, Dr. Clearfield. We'll be taking our break. We'll resume this afternoon at 3 p.m. with a dermatology lecture from Dr. Cachet. Remember, fill out your evaluations and your CME reporting forms for those virtually. Email them or fax them to me. Those here on site, we have a box out at the front table. Again, thank you very much.